All right, I guess I will start with introductions. This is simultaneously one of the easiest and one of the hardest introductions I've probably ever done. Welcome to Medicine Grand Rounds on this very final Grand Rounds of 2023. And I will preemptively say happy holidays to everyone, and I hope people have some time with family or friends and time to get some peace and hope for more peace. So I am so excited to introduce my very dear friend, Dr. Matifadza Hlatshwayo Davis, who was appointed Director of Health for the City of St. Louis in 2021. And in that role, she has become an internationally recognized expert on public health and health equity, as well as an infectious disease physician. But I have known Dr. Hlatshwayo Davis for a long time. She earned her medical degree from the Cleveland Clinic Lerner College of Medicine and a master's in public health from Case Western University. And we met at that time when she was a first-year medical student. And I will tell you that at that moment, from those moments, I knew that she was extraordinary and destined to really make a difference in this world. She may refer to me as a mentor, but I will tell you this is one of those situations where the mentee has vastly eclipsed the mentor, and I'm so happy to be in her orbit. Dr. Hlatshwayo Davis then completed her internal medicine residency at University Hospitals at Case Medical Center, then her ID fellowship at Washington University School of Medicine, where she specialized in HIV and STIs and got additional training there. And then stayed on as the Associate Program Director for the Fellowship and a clinical instructor, as well as having positions of leadership in the Office of Inclusion and Diversity at WashU and at the John Cochrane VA Medical Center there in St. Louis. But in 2021, she was given the opportunity, or she won the opportunity and was appointed the Director of Health for the City of St. Louis by those who recognized, again, the work she was doing in the community and the difference that she was making even at that stage. And so she took over as health director at a time when COVID was really launching and led the COVID-19 response for St. Louis, which was actually applauded by President Biden in 2022 as really an exemplar in the country. She also, and I don't know if you're going to talk about this, established the health department's first behavioral health bureau, which I think is really visionary and important and a way we need to think about moving throughout the U.S. She did many other things. She's expanded the size of the health department dramatically. And I could go on about that, but, Dr. Hlatshwayo Davis has been a voice for healthcare disparities and equity, which are, longstanding issues we're all aware of, given our footprint in Atlanta, but which really achieved, I think, greater national recognition during COVID-19. She's also been recognized as an extraordinary communicator to physicians and communities alike, and then can uniquely bridge that gap to move the needle toward health equity, implementing change in St. Louis that I think, again, is something we can all learn from. And I think, Mati, you will have, as you know, I think a crowd here who's very interested in equity, again, given what we do here in Atlanta. She has received accolades at the National Society level. She has received the Society Citation Award from IDSA, and I think is probably one of the youngest winners of that in recognition of exemplary contributions in the field of infectious disease. And she's a member of the IDSA Board of Directors. She's now a sought-after speaker. And so we are very lucky, Mati, Dr. Hlatshwayo Davis, to have you join us here today. And I have taken way too much time, but you are special to me. So I will turn it over to you.
It'll be hard to get through this one because it's intense. It's incredibly personal, as you can tell. To have your oldest mentor, who is one of your closest friends, give probably the best intro. So if we could just package that and send that to every person who introduces me henceforth, that would be fantastic. But I also want to point out that I don't get nervous for grand rounds anymore. I do a lot of them. This one I'm nervous because I stand on the shoulders of giants. Dr. Wendy Armstrong, who has been my rock in the field of medicine since I started my journey in medicine, my day one, day dot. Dr. Kimberly Manning, who you all know as Grady Doc, but who Black women across the country know as our covering our mentor, our sponsor, our friend, and she fights on our behalf every day. And then to have friends like Dr. Wiley, who creates safe space and is my biggest cheerleader in so many ways. So this is very special for me. It's special for me because of the amount of respect I have for Emory University's infectious diseases department, for the way that you have set an example for how it should look to create equitable pathways for the people that work with and for you, and for the people that we serve. So I'm so honored today to be able to talk to you about reducing barriers towards health equity, navigating challenges within public health. I have no conflicts. And of course, so the objectives for today, you know, sometimes this slide can be challenging for me. There's always really good objectives, and depending on where the spirit moves, it could go in different ways. But what you're going to hold me accountable to is really talking about the challenges in public health funding and the public health workforce, examining ways to promote public health advancement through academia, and through it all, to propose all of that through equity-based solutions for public health education. This is not going to be your typical grand rounds. It's not very academic, very data-driven. Public health is in the house. And so I'm a storyteller, and I don't believe that a story is complete without understanding where a leader has come from. And so many of the leaders that do lead you, our personal stories are a big part of who we are and how we lead. So I'm gonna start there. I was born and raised in Harare, Zimbabwe. And if I was there in person, I always take a poll of the room to see how many people know where Zimbabwe is and could point it out on a map. Being that we're on Zoom, you guys get off easy. I'll tell you that it's less than 20% rate of people being able to point out Zimbabwe on a map, which is deeply insulting to your girl. But we moved. And so Zimbabwe, that sits right on top of South Africa, the southernmost country in Africa, about the size of Arizona, if you look at it sort of geographically, and a census that I still cite from many, many years ago and could be woefully incorrect at this point, of 14 million about 10 years ago. The heroine of my story is the woman in the top left for me, I hope top left for you on the slide, my mother. This is a woman who raised 3 women in what you call a low-income country. And my father was plucked from his village as an adolescent just before his 15th birthday to fight for the war for independence for our country. I want you to imagine what that should even be like. That's like a horrific thing to even have to say, but it is true. And so he was shipped away to learn how to fight guerrilla warfare, because the native Zimbabweans did not have the artillery of our British colonialists to be able to fight for that war for independence. And so he was sent to China. And it's always interesting to me that most people to this day don't know my father's name, even though he's very well known in political circles for his role in our country's independence, because all of the war veterans got war names from China. And so my dad is known as Comrade Mao. People meet me and they're like, oh, you're Comrade Mao's daughter, because he was named after Mao Zedong, a Chinese general at the time. And so this young man spent all of his adolescent years overseas and then fighting for a war for independence that we gained in 1980 when he met my mother. My earliest memory of my favorite picture of my mom is her standing outside the first Air Zimbabwe airplane. So this to me is always symbolic of the hope and the freedom and the liberation for inclusivity for our people once we gained independence. My mom stood outside of this Air Zimbabwe plane, as the youth say, and my little sister says I should never say, but I say it every time I can to embarrass her, snatched for the gods, and with an afro that circled her head, the most beautifully picked out afro, and really a time for Black Zimbabweans to share the same freedoms that they hadn't been afforded in colonial times. And that story takes us to a really sort of sadder part in the history of my family, where my father, a war veteran, was not able to assimilate. My dad is known as one of the nicest men you could ever meet. When people see me now and they talk to me about my dad, they say, wow, he's the nicest man. He did this and this for our country, or this and this for, you know, me as a person. But my memories of him are challenging. You know, this was a man who never had the tools to learn how to be a father, a husband, and certainly a family man. It was common for me. My favorite memories of hanging out with my dad before he passed was being in bars with him, with other war veterans. This was normal. But what was not normal was that, unlike what we have today, there were no veterans hospitals. There was no Medicaid and Medicare for folks. So these war veterans came back with so much internalized and externalized trauma and no tools to be equipped. So my mother and father divorced at a very young age, and we lost him to disseminated cancer when I was 15. This is one of the major reasons why it was always going to be medicine for me, because that relationship had soured after the divorce. We didn't see him a lot. Like I said, he wasn't a very capable father, but we also didn't know he was fighting this battle, likely due to years of heavy drinking that a lot of our war veterans did, that resulted in liver cancer. And so I remember the guilt I felt when my mom earnestly tried to get us to his bedside to say goodbye before he died, having hidden his diagnosis from most people in his life. We were not able to say goodbye and to even know that he was as ill as he was. And I remember the guilt of that as a 15-year-old, and just hoping and wishing that his medical team, his doctors, were good people, people who took care of him and nurtured him. The second big part of my why was the death of a matriarch of our tribe. I had a great aunt, and she was one of the most beautiful, wise women in our culture. And she passed away a few years after my dad did. And funerals in our culture are very, very joyful, happy events. They're week-long. It's like a family reunion. There's eating, there's drinking, there's introduction of family lines. This was a muted affair. This was one day. It was dark. There was a negativity that almost hung in the air. And that was my first experience of what stigma was, because I found out as an adult that she passed away from the complications of AIDS, having married her husband a virgin, and his infidelity resulting in them both ending up with HIV and dying from AIDS. This was devastating for me. And so again, at a very young age, it was not only going to be medicine for me, but always infectious diseases. At the age of 18, my mom put her oldest daughter on a plane halfway across the world. Education had always been what she had taught us would be our ability to find our dreams and to not succumb to poverty in the way that she had grown up, in the way that she feared we would be destined for. And so education, one of the first gifts she ever gave us was a bicycle, but it came with a library card, and it was, you need to read, you need to get good grades. And so I got a full scholarship to a small liberal arts college in Springfield, Missouri. And I always say, for those of you who know me, you know that there's a high likelihood that this mouth may mean that this job security may not always be there for me. And I always say that I will sell the movie rights to the 2-day Greyhound bus drive from Washington, D.C. to Springfield, Missouri. Springfield, Missouri, folks, the 9th whitest city in the United States. So there is no greater culture shock than to drive through cornfields for 10 miles going into Springfield, and also going from a country and a city where most people look like me to Springfield, Missouri. Yet I will say without question, one of the most nurturing environments I have ever been a part of. I spent 4 years there, and this started a journey of intentional mentorship for all of the small town that it was. I was supported, and one of the trustees there was also a trustee at the Cleveland Clinic that was starting this revolutionary new medical school that graduates physician scientists, and was able to organize for me to do an internship. So I went to Cleveland, the picture in the middle there, my white coat ceremony, this new medical school between Cleveland Clinic and Case Western Reserve University, where I was also able to do a master's in public health. The dream always to get an education and a master's in public health, thanks to my first ever mentor, Dr. Wendy Armstrong, who told me that it would be wise for me to pursue a master's. At the time, one of the advantages of this medical school is it offered free additional masters. And so she knew that as an IMG, I may not have those opportunities. So I have Wendy to thank to this day for my MPH. That I don't know, I would have been able to get Aura forward had I not taken advantage of that opportunity. The plan always to go back home to Zimbabwe. I knew that for me, it was not just about excellence in clinical care. I knew that if I wanted to make a difference in infectious diseases and specifically public health, that I would need that MPH, that I would need an understanding of what it means to really tackle these devastating health outcomes, specifically in HIV, where Zimbabwe was one of 4 African countries that for a while were in the top 5 incidence and mortality rates for HIV and AIDS worldwide. And I knew that that would require an understanding of not just clinical care, but really public health and the socioeconomic factors that impact it. But you make plans and the universe laughs. And I met my hunk of a husband. You see that gorgeous picture of us on our wedding day there on the screen. And so I followed him with a ring on my finger to here to St. Louis, where I did my fellowship. You see this gorgeous picture of me and my co-fellows, and had 2 beautiful babies that you see there, that perfectly picture in the sunflower seed. So this story couldn't be any better. This is like the dream, right? But with every story, there is what is happening in the background. And I will say that medical school and more so fellowship were really challenging times. I did not see, there were not a lot of people that looked like me. I was tokenized. The affirmative action movement that was supposed to be something that would uplift minoritized folks and make sure that we have same opportunities was often weaponized, right? I was told not to use the race card, but it was often used against me. If I got a promotion or if I got an award, it was, oh, look at them, you know, placating or making sure that they diversity card. But more than that, it was just not seeing people who even wanted to do the sort of things I wanted to do in academics. Traditionally, we see a lot more support and visible pathways for equitable promotion and advancement for basic science and clinical researchers, most of whom are my closest friends. And of course, I understand the necessity, but it left me feeling alone and on an island. And this culminated in many years where I lost my confidence, lost myself, was not clear on how to promote, self-promote, but also to find that those intentional mentorship and sponsorship pathways to really promote my journey. So once I left fellowship, really a shell of myself, really riddled with so much imposter syndrome, I went for a fully clinical pathway with a joint appointment at Washington University and the John Cochrane VA Medical Center. And, you know, we all know this in academics, or traditionally, people who work at the VA look like they can't hack it in academics and it's not as competitive. But for me, couldn't have found a safer place and a better place to gain my confidence back, and more importantly, to really start to flex my health equity muscles, what I always wanted to do, public health, on that bedrock of health equity. But so much imposter syndrome, had not really found a pathway. And then 2020 came. I was a second-year faculty member, 7 months pregnant at the beginning of a global pandemic. And I, you know, at this point, well, for one, this is where ID shines, right? Nobody's really checking for ID most times of the year, but let Zika or Ebola, and specifically COVID-19 came, and we were the gods of the hospital and the people that folks across the world look to. So I was dealing with that. I was the only Black woman, the only Black person in my division, the only pregnant person in my division. And we were now taking the lead in this global pandemic. In April of that year came Black Maternal Fetal Health Week. And I was also now bombarded with statistics that told me that I was 3 to 4 times more likely to die than my white counterparts. So in the midst of all of this going on, there was that too. And I remember the stress that had on me. My baby came early. 2 weeks after that, on lockdown, on maternity leave, breastfeeding every 2 hours. With a 3-year-old, none of our parents able to come and support us. So my husband and I with a newborn and a 3-year-old in the house. George Floyd was murdered. And everything changed. For one, I couldn't even watch the video. Couldn't watch it, because this is not new in communities like mine, where we continue to have this acute and chronic trauma from these stories, from these injustices, from these brutalities in our community, and we're expected to show up every day and still do what we're supposed to do joyfully, right? So as a new mother, I couldn't watch a video of a young Black man calling out for his mother as he died in broad daylight. Couldn't do it. About 3 weeks into my maternity leave, I remember breastfeeding our new baby, putting her in the bassinet. My husband was snoring next to me. It was like 1 o'clock in the morning. And I finally put my headphones on and I watched. And that was the turning point for me. To finally really reckon with the really difficult path I'd had in medicine, to reckon with what was happening in my community. And by this time, we were bombarded with statistics at the beginning of this pandemic that minoritized communities were 3 to 4 times more likely to get COVID, to have serious illness, or to die. And when I turned on the news, I saw a lot of experts, well-meaning, very few in infectious diseases outside of Dr. Fauci, and certainly none who came from minoritized backgrounds. A lot of old white men on TV. And so I knew that this was where my calling was, where I had to overcome my imposter syndrome, where I had to be confident enough to authentically walk in the path that I knew was for me. And here I was, a Black woman immigrant who also happens to be an infectious diseases doctor trained at some of the best institutions of the country, who cares deeply about these inequities. And everything changed. Within a month of accepting one of the first interviews at a local TV station to talk about COVID-19, I started punting those when I was when I had imposter syndrome. I was on CNN within a month. I never thought they would call me back. I definitely knew that once I said racism, health equity, and a couple of other, controversial words or topics, that this would be a one and done. I remember the first days the producers call you. They call you and they say, for your first time on CNN, I don't know what this accent is, but let's just go with it. We expect people to wear their hair slicked back and to wear pastel colors. And I showed up with a fro and a print because I was going to be the representation that I did not see for our communities, who had valid lack of vaccine confidence, who had valid fears and mistrust and distrust in government and in medical communities. And that skyrocketed. You see before you, I was then called for the next year as a medical contributor across platforms, CNN, BBC, Al Jazeera. My favorite picture, if you can zoom in on the screen, is me breastfeeding our baby about a couple of minutes before going on MSNBC Live, handing her over to my husband and going live immediately. And that shows really what some of the leaders, especially women and people from minoritized communities, what we have to balance, what we have to overcome, and how I really did use this new Zoom environment to be able to be a new mother and go into and walk into my future. But then came a time where I had to make a decision because I was struggling in academics. I still was not seeing clear paths for equitable promotion and advancement. This was not happening for me in the same way that I saw it for others around me. And so what were we dealing with at the time was really figuring out what my future looked like. And so in self-advocacy, I resigned. And 4 months later, the same community that I had worked in, the same environment where after hours, never made it to evaluations, I was really in the community, for the community. They are the ones who went to the new mayor of the city of St. Louis and said, this is who we want to be our director of health. And so and this is October of 2021, the state of—
Hey, Mati, we just lost your slides. Or they're like, we've got back to like the other, yeah, there you go. Go for it.
What are you seeing on the screen right now?
Health funding per person.
Okay.
You're good again.
Try to go back and keep going.
No, you're good. We just like for just an instant, I stopped you right away.
Yeah, we just lost a couple of slides, so I want to go back.
Oh.
So the state of public health, when I took over as the director of public health, could not be more dire. We were charged with being the implementation arm for this pandemic. We had significant disparities. And for me, this was specifically dire for the most vulnerable, as I stated earlier. And I worked in a department that was woefully woefully deprioritized within the state I was in. So let's talk a little bit about what was happening. This is from a 2021 Public Health Workforce Interest and Needs Survey, which shows that the public health workforce at the time was primarily white, female, and over the age of 40. The workforce has become more diverse and mirrors the US population more, but there is less diversity at senior levels. 66% of all executives identify as white. Furthermore, if we look at what was happening as far as funding for public health, right? I was in a state that is 50th out of 50, lowest of all 50 states and the District of Columbia in 2020 in public health spending. In this state, we believe that public health is worth $7 per person state public health funding. That is abominable. Let's take a look at how that compares. Comparing Missouri to surrounding states, they spend more per person in public health funding significantly. Iowa seeing some aggressive peaks in 2016 and again in 2019 and 2020. Lack of funding leads to a slow response to this COVID-19 pandemic for us. It exacerbated its impact, particularly in low-income communities, communities of color, and for older Americans. And so I was taking over the helm at a state where this was true, and where also I inherited a public health department that was a quarter of the size that it should be for a city this size, and a budget that was 1% of the city's budget. This in comparison to 52% for public safety, and even parks and recreations of 4% of the city's budget I had won. So while I had lofty dreams, I took a month to do a listening tour. I spoke to health directors and commissioners across the country. I realized in my first staff meeting on day 2 that I had to change all of my plans for my externalized priorities, as you see here on the screen. As I spoke to my staff, the only thing I heard over and over is we are burnt out, we are undervalued, we are underpaid. We are burnt out, we are undervalued, we are underpaid. So I had no choice but to, in parallel, internalize and externalize my priorities, to really focus internally on creating a culture of openness and establishing an infrastructure of policies and protocols. Externally, though, we were a month away from the largest surge in the COVID-19 pandemic, the Omicron surge. So I had to focus on COVID-19, but every other part of health and public health was on fire. We hadn't had the capacity to really delve into it, and some parts of it had been in crisis before the pandemic. Here in the city of St. Louis, if you don't know, St. Louis, year after year after year, #1 in the country for violence. So violence prevention had to be a priority. Behavioral health had to be a priority. We knew the opioid crisis was a crisis before COVID and ballooned within crisis. The maternal child health crisis in Missouri, the bottom 5 states every year for maternal child health. Really everything else was on fire. And for me, unapologetically leading with that lens of health equity, which I was very honest with the mayor when I interviewed with her, had to be a priority. So let's talk a little bit about some of the major things that I did to really address these critical issues in my tenure, my 2-year tenure so far. And then I want to talk a little bit about how we can really prioritize public health in our academic institutions. I had to be innovative. We were in a COVID-19 pandemic. We had a significant issue with lack of vaccine confidence in minoritized communities. And so I had to really think about how I would address this. One of the ways I leveraged my personal relationships coming into this role with the professional task ahead of me was Dr. Rochelle Walensky was coming to St. Louis to give grand rounds at WashU, her alma mater. We had intersected in my prior life on national COVID-19 strategies and engagement. And so her office reached out and said, you know, she'd like to meet with you for an hour. I counted that and asked for 6. Because I knew it was important to take advantage of this opportunity, the first health department she had visited in her tenure as the CDC director, to really give her a hands-on look at what it is to be in public health at this time. And also the theme for her visit for me and my team was health equity in action. For the first time ever, I reached out to all 4 CEOs of our federally qualified health centers, and I asked that they make an hour and a half available to meet with her in a closed door meetings. I had the team here at the health department take her around, be the ones to speak, because they're the ones who do the work, but also because these burnt out, undervalued, grossly underpaid people deserve these opportunities to shine and to be given their due credit. But I also use that as an opportunity to ask for support in bringing in the first ever behavioral health bureau for the city of St. Louis. As you saw on the prior slide, behavioral health and violence prevention, maternal child health, all 3 in crisis. But when I took over on day 1, horrified to find out that not one person was hired here to do the work of violence prevention or behavioral health. The few programs we had all contracted or subcontracted out, not an efficient way to lead a health department to be able to have control over your vision if everything is subcontracted out. So that resulted in Director Walensky providing us with 7 CDC employees through CDC initiatives that were made available to us. And that bought me a year to start the foundation for a strategic plan, for an implementation plan. I also advocated for a health equity expert to come in and do a health equity plan for this new bureau. This allowed me time to work with a city system that is damaged. Department of Personnel taking 6 months on average for us to even hire an individual. That being really, really made difficult by non-competitive salaries. In my 2 years here, we've hired over 119 people. I worked to build out a communications bureau so that we could really bring public health to people in accessible ways and increase our community engagement through all social media platforms by over 300% in my first quarter. Really made it my mission to advocate for increased salaries, retention bonuses, and advanced starting salaries, and improve staff outcome. We did a survey in my first month to see how people felt about working here. 60 different questions. We redid it a year after, building a QI team, building a team of 2 epidemiologists to 10 to have a data-driven approach. And we increased every single metric from that survey by a range of 9 to 35% in 1 year. So really working on that internal strategy whilst dealing with equitable ways to deal with COVID in the community. During that time, we had a historic flood. We had to give out more than 45,000 doses of COVID-19 vaccines. But we were able to do this work in such a way that we brought much needed value to internally, but put our department on the spotlight, culminating in an invitation to visit the White House's team. And so what that meant was a total restructuring of the department to support these efforts. When I came, it was just me, a big gap, and then most of the low-level people at the bottom. But we've now made critical hires with an administrative and operations core to support public health. These are the things that we've had to do, that the public and most of you probably don't realize we have to do to support this work. But now let's talk about the future of public health. And let's talk about how this can be supported in our academic circles. You would think this is a new topic, a new thing that we have to do. But supporting public health is nothing new. 35 years ago in 1988, an Institute of Medicine report titled The Future of Public Health said at that time that the nation had lost sight of its public health goals and allowed public health to fall into disarray. The report noted that America's public health system was expected to do too much with too few resources. Let's take a quick look at what they said. The future of public health looked at needed improvements in academia regarding the education of public health professionals. Academic institutions already perform 3 important functions in public health: conduct basic and applied research in disciplines pertinent to public health, educate and train public health workers, engage in community public health and professional services. So let's begin with the funding of research in the social and structural determinants of health. At the time of the report in 1988, public health expenditures had been declining over the past decade. Only 1 to 2% of funding was spent on prevention. Fast forward to 2013, the Network for Excellence in Health Innovation found that only 6% of national expenditures were spent on making care accessible, while a whopping 90% of national health costs went to medical services. At its core, disease prevention relies on science, particularly science that predicts what will happen if we don't act. Currently, the NIH invests much of its $45 billion budget on medical research. 84% of that extramural research through grants, while 10% is for NIH scientists. Looking at the graph on the left, about 20 years ago, we saw a shift where what we were spending per capita on healthcare expenditures superseded the percentage of national healthcare expenditures. While the NIH funding is split heavily on extramural research, when broken down between basic versus applied, over half of NIH's research funding supports basic research. That works when you're looking to advance knowledge, we know that. But when it comes to implementation, finding a solution, less funding impacts not only those affected as a community, but also down to an individual specific needs. One of the reasons I believe that public health at the local level, where the real work happens, is compromised. Moving from research to education and training, let's do a quick reminder of where public health work is historically rooted. Public health in the United States dates back to the late 18th century with the creation of the Marine Hospital Service. Early on, and still today, public health works to improve sanitation and cleanliness, ensure safe food and drinking water, control infectious diseases, and provide vaccines. That's really the backbone of what public health departments do, and what most of my now 127 staff do, but are not supported to do, and certainly doesn't get as much attention. If we cross-train medical and public health students, both begin to understand the importance of epi, biostatistic, public health policies, and elements of prevention. To me, this is key and needs to happen. Academic institutions have the opportunity to help train our young professionals following these recommendations by the Pew Health Professions Commission, I beg your pardon. We need to be increasing integration of interdisciplinary learning opportunities, include appropriate incentives for faculty to undertake interdisciplinary education courses. This could be creating a certificate or recognition program which encourages them to take courses in public health. Let me talk to you briefly about the work I'm doing here. One example is I serve on an external advisory board for a new school of public health at Washington University. As one of the only local public health leaders, actually the only one, the rest are national leaders. I'm able to advocate as they're building budget, as they're building the foundation for this new school of public health, for innovative strategies to increase workforce capacity. What can that look like? Well, my staff hate interns. Oh gosh, every academic loves to email me. Can we send you interns? They'll be here for 2 months. And an internship at a local public health department is a time where people just coincidentally get COVID. Their dog dies, they're sick. You know what I mean? Because this is their time to take vacation. By the time we've spent all of the time that in investment in training them, they're gone because they're short term. So we want to see academic institutions really commit to innovative strategies like paying a percentage of a faculty time over time to be invested in a local public health department so that they manage the students. And no matter what turnover there is in students, there is longevity. I've done this in a new MOU that I just signed with the law school at St. Louis University, where their public health law professors are going to be giving X% to my health department. Their graduate students are going to be working on auditing current public health policy, helping me keep up with new public health policy as it arrives, trans care, which is a hot topic right now, the downstream effects of what happened when Roe v. Wade was turned over. There is no time or capacity with everything on my plate to be able to do that. And we're able to do that through these innovative MOUs. These are the sort of things that academic institutions should be looking at. So my other strategy and the way that I lead, again, is really rethinking how we engage with community. During COVID-19, I had 2 weeks when I started the job to come up with a comprehensive pediatric plan for the city of St. Louis. I restructured what that looked like. We knew that the big academic institutions have the money, have the resources. But if you know the history of what's happened in Black and Brown communities, specifically in North City, now that I've built out that EPI hub, we have data to show that the same disparities across all disease states are in the same neighborhoods. And when we do surveys and visit with these people and do our community outreach, they tell us of the valid mistrust they have. So it was flipping that on its head and saying to the academic institutions, we need you in this fight, but you've got to be in the background. You don't get to be at the mic. You don't get to be the guy. It was forming weekly meetings with federally qualified health center CEOs and the school superintendents across the city every single week. And they were the heads. They were at the mic. It was understanding who the trusted messengers were, who earned the trust of their communities, and making them the visible leaders, the people that we look to, and the rest of us give them the support. It was taking vaccine distribution and education outside of my building here in downtown St. Louis to community centers, to schools. This is how we led upon a bedrock of health equity. And so for me, through collaborations like working with academic institutions and those trusted members, we're able to focus our efforts to address very valid, present, historically, and current systemic and structural, measurable, and avoidable health differences in populations. These multidisciplinary and global approaches allow us to develop network of collaborators, optimize use of new data platforms, and really focus on innovative ways to build KPIs and metrics that are focused on health equity, develop transdisciplinary training platforms, embrace inclusive research themes, and really look at some of the traditional ways that we do this. Outdated, often are just, not well thought of. We're not thinking about the innovation and how to engage communities, and develop platforms for innovative research using some of the examples provided here today. So when I took this job, I was unapologetic about leading in this way. Health equity for me is saying out loud that the reality is that not everybody enjoys and thrives in the same way. Equality, where we give everybody the same, did not cut it. Equity means unapologetically providing the resources to that disproportionate impact so that we can all reach liberation. This must be the way that we lead. This is the way I lead. And so that means innovative approaches. I'm running out of time, so I won't talk a lot about our at-home testing kits, but I know I don't have staff. I know that I don't have capacity. So when we're talking about ending the HIV epidemic, it's about updating our websites, our data, getting community health workers in the field, but giving people at-home testing kits and really working on them, working against stigma and empowering people to be able to take those tests so that we can link them to care. In the interest of time, I'm not going to talk about mpox today, but needless to say that a lot of what we went through, I know you went through. We thought we were better prepared, being just coming out of a global pandemic. We were not. But one of the things that was important to me was doing a 2-hour meeting. Before I rolled out my mpox plan in the city of St. Louis, we invited 35 of the LGBTQIA+ and Black and Brown leaders to really hear from them. What are your concerns? You've been seeing what's happening on the coast. You've been seeing how mpox is being handled globally. What do you need from us as your local public health department? And it was through active listening that we then built our plan, through culturally competent, inclusive messaging that was used by multiple health departments across the country, and that culminated in us getting that support, using that meeting to build listservs so that we had the largest single vaccination for mpox clinic across the state at a time where it was like the Hunger Games and there were not enough vaccines for everyone. So in looking forward, sorry, I need to go back one. And looking forward, there's a few ways that I believe that you can be equipped to really do what needs to be done here. We know that academics has made major contributions to prolonging life and increasing the quality of life through research. Basic science has provided that knowledge that's necessary to develop precious vaccines and protect against debilitating diseases. However, comparatively few resources have been devoted to supporting prevention research, community-based research, truly integrated and translation, innovation translation research within this space. This is where we should be focusing our efforts from a research perspective. Such resources must be found and allocated if we are to continue to have a major impact on the health of the community. With the collaboration and partnerships of academia, I really believe that there are so many promising ways that we can move this conversation forward. In looking ahead, I also believe that how often do we as clinicians treat the patient and fail to consider if the aspects of their life impacted their condition? I remember having the highest retention rates in my HIV clinic when I was still in academics. And one of the simple things I did was really just respect the fact that many of the people in the most vulnerable communities take 3 modes of transportation to get to our clinics. They walk to a bus stop, to take another bus, to take a bus, to walk some more, to wait an hour and a half in our waiting rooms, to be put in a room, to wait for a student, wait for a faculty member, then be told to go wait for labs. And then a lot of them need to wait to see if the case manager or nurse can help them get what they need to get home. Unacceptable. I had a team-centered approach. Many of my patients saw me, their nurse, their case manager, their behavioral health specialist as a team. I would often come early to clinic and pre-round with those members of the team. Sad to hear them say, you're one of the only physicians that really listens to us. When I was on inpatient rounds always started at the bedside with the thoughts and feelings about the plan that I had from the nurse, right? So we have to be thinking about how we can expand our ability to really teach the future of medicine, but also to come up with innovative strategies to invest in a physician public health practitioner to teach, innovate, and above all practice in a way that really addresses these social and structural determinants of health. And lastly, I want to talk about what you can do. We really need you to raise your voice as a medical leader to increase visibility and literacy about the role of public health and the impact it plays. We've got to see immediately and moving forward support for funding for public health to ensure every community has public health services, investment in research, development and delivery of new vaccine treatments and diagnostics. We've got to enable a structure of data systems to detect health inequities and links to action. And above all, we need to diversify and pay a public health workforce that is equipped to provide a broad range of needed services. So I'm going to pause here, and my final thoughts are for the trainees amongst you. If any part of the intro of my talk resonated with you, if you are a person who is not only seen, if you have struggled, if you are failing forward, and if you don't know where to turn, I am an example of an alternative path that can not only be successful, that is living my authentic self every day. So this is a quote. When I was building my platform in COVID-19 as a medical contributor, I went from having 200 followers to over 18,000 in really engaging with the community. And it reads as on your screen. One of these days, I will tell my story in full. But for now, trust your instincts, know your worth. Be brave enough to forge your own lane if it does not exist. Choose your mentors, and I would say sponsors, wisely. And above all, do not be afraid to step into your purpose, because it is absolutely beautiful here. Thank you so much for having me. I will take questions or comments at this time.
Mati, thank you so much. That was really inspiring, and I have so many questions, and there are many also that are in the chat. I'm going to supersede the chat and ask a quick question first, and then grab these questions in the chat. And I guess one of them is, you know, you had an MPH as a medical student, and then you sort of went through the traditional academic pathway, and then somehow, and I'm still a little mystified by this, you stepped into the role as a city health director and started making change. What do you advise the people on this call who are listening, who would love to have a role like yours? How do you get the training to do that? I don't know where you got the training, like how you did that, but how could others prepare themselves for that sort of a role?
Yeah, I struggle with this, Wendy, and I love that you asked that question, because I would never mislead any trainee on this call or across the country to believe that I wouldn't even want my story to be reproducible. So let's start there. I want to say out loud and without apology that I was failed and that we should do better in academic circles. I trained to be in academia, and while I believe that I can't be the bread and butter, someone like me of academia, we should be advancing and promoting people who are different and who do provide a level of support and what I believe is prioritized care and skills within academics that a lot of our, most of our basic scientists don't want to be communicating or don't want to be in the community. But in order for us to retain those folks, we have to be intentional about those pathways. So it starts at the top. We can no longer check off DEI, inclusion, and diversity or health equity as a checkbox. We have to be intentional. And that starts at the top. Are we able to really put funding into innovative, not just recruitment, because we love to bring them in, but what are we doing to retain folks in academics right now, right? And I think that's something that Emory leads in, and I think that's something that even you all can continue to innovate and grow in. But so my story is not one that should be reproduced. We shouldn't have people leaving. We should have people entering into this pathway if this is what they want and with intention. But I don't want that to be from a pathway of leaving. Having said that, I think it's important for folks to know that there's so much so that you can train with, and there's so much so that's my superpower. I always say to my mentees, what is your superpower? For a long time, I felt like the particular strengths that I had were soft skills or secondary skills. It wasn't as impressive as, you know, scoring really high on a standardized test, right? But the ability to communicate, the ability to touch people, make them feel safe, laugh in a difficult situation is a great skill. If I'm being honest about what my superpower is that has grown my department by 30% in one of the highest turnover environments and engaged the public, it's been that. But I will say that really understanding and developing relationships, which is harder for my introverted trainees in mentorship, but specifically sponsorship, is key. Because if it weren't for a Wendy, if it weren't for a Kimberly Manning, if it weren't for people who at my lowest moments and when I left and didn't think and thought my career was over, people who would advise, pick up the phone, people who give resources, put you on grants. I think about your incredible relationship with Carlos over the years and how you always told me you never, you know, research was never your thing. He does that, and what you two have been able to do for medicine and infectious diseases is incredible. But that requires intention, and it requires those of us who are in leadership making sure that every single trainee that we look after has the same opportunities for that type of intentional mentorship and sponsorship, and we don't leave folks behind. But I will say, I do not advocate for a career that's born out of failing forward in trauma. I want us to allow people to thrive in all of these different ways: basic science, clinical research, public health, new pathways that others are creating with intention and with support. Does that help, Wendy?
Yes, it does. Question from the resident room. In addition to talking about how inspiring you are, they wanted to know, have you found a useful way to get medical messages out to the public in a time of scientific distrust and misinformation?
You know, we have to just reckon with the fact that we did not do a great job in the first year and a half to 2 years of COVID. I don't think we took as seriously how important communication was as the development of these groundbreaking and innovative vaccines and other scientific opportunities. And I think this has to make us have a greater amount of respect for what public health is, which truly is the implementation arm of medicine in my mind. For me, I do think that we have to know that not everyone is, as I've said in the talk, the guy. Not everybody is comfortable with that. One of my other superpowers is I love taking really complex issues and making them accessible. This is something that the great Dr. Kimberly Manning does so well. If you follow her on Twitter, if you go to one of her talks, her ability to use stories to really teach us in ways that we don't even realize we're being stirred from within while we're in it, that is a skill. That is sometimes an it factor that you don't have. So it is sometimes just saying, I'm not the guy, and taking a step back and letting people who do communications do it. And for us as divisions and departments to invest in communications for both our clinical practitioners and those who are going to move forward the message of public health. So for me, it was a few things. When I was dealing with a lack of vaccine confidence, and you hear me never say vaccine hesitancy, I find that term offensive. There's nothing hesitant about what minoritized communities have gone through since slavery, through the ages, and currently to have valid mistrust. Lack of vaccine confidence puts the onus on us, right, to really do the work to increase that confidence. And for me, it was simple strategies at the individual level. Coming into a patient room, an inpatient or in the hospital, I'm not a big white coat person, coming in with a big team, talking down to a person who's vulnerable in a bed, not being thoughtful about their privacy. Little things like sitting in a chair, eye to eye, sitting at the foot of the bed, making sure the curtain is drawn, and then not talking at them. Just a simple open-ended question. What questions do you have about COVID-19 or the vaccine today? And then hush. We talk a lot as doctors. We love the sound of our own voices, Jesus. But sometimes we've got to listen, because Black people, brown people, people from all types of minoritized backgrounds are not a monolith. And so their valid mistrust or concerns may not look the same. And then for me, it was then speaking to them at a level they can understand. Not data, not big science, not big medical terms, just everyday language. I would make fun of myself. I would talk about the fear I have of getting shots as a doctor. How funny is that an infectious diseases doctor is horribly afraid of needles. I would talk about what my side effects look like on the day. And I would sprinkle that with the medical data and answering their questions. So that is at an individual level, it was having a simple, but an approach that gave dignity and respect and was not condescending to these populations. At a macro level, like I said, it's investing in making sure that people really are trained in how to speak to individuals, whether it's one-on-one or at a mass level. This is not something you just do or have earned the right because you spent X number of years in medicine.
All right, I have two rapid fire questions because we're at the top of the hour, but I think they're two important ones. I'm going to give them to you both at once. I'll remind you of one if you forget.
Okay.
The first is, you are in Missouri, which is not always the most progressive state, much like ours. There's so much anxiety among our LGBTQIA communities, particularly our transgender communities and gender expansive communities, but frankly also for for rights for the LGBTQ part of that as well. How do you as a public health leader sort of try and meet those challenges? That's one. And then the second one is also sort of a left out group. You're the director of health for the city of St. Louis. What about all those rural communities that don't have a big city health department operation? So if I could rapid fire those in our last couple of minutes.
Rapid fire. So the first thing is whenever I hold myself accountable, it's at 3 levels. What am I doing at my platform at a federal level, a state level, and a local level? Got to shout out IDSA, past president, Dr. Carlos Del Rio on the call, a mentor, a friend. IDSA has done more to move the needle forward and really put these messages across at a federal level. So advocacy is possible, whether it be through your medical associations or your infectious diseases society, which is active in advocacy right now, right? But I also have the privilege of sitting at the table at these national calls, and that's my job. That's not a job everybody else has. At a state level, what are you doing to understand state policy? And so I knew I didn't have capacity for this, Wendy. I couldn't be organizing mass vaccinations, communicating with the public every day, dealing with every single KPI across 8 bureaus. And so that building capacity for public health policy through a law school that I'm partnering with, and then advocating for the mayor who did hire a state level lobbyist and policy specialist to work with us in the city, I can now move that work forward. Making sure that we're publishing and talking about, which is why I give talks like this, what we're doing, so that other people can model the same sort of things we're doing. So I built capacity for policy. And then at a local level, it's listening, right? I am unapologetic about who I am as a leader. I'm very fortunate to have been hired by a mayor that gives me room to speak. So even though I'm in a state that's probably reflects different politics than the politics I personally have, at a local level, I'm empowered to really listen to what's happening. So even when state legislature and city legislature does not allow me to support the LGBTQIA+ community when they're under very visible and real attack, I will put out a statement unapologetically. I will bring leaders together unapologetically. I will work with policy folks in the mayor's office to see what we can advance. And then for rural communities, I'm not a rural leader myself, but there are incredible organizations like the one we have in Missouri called MOSIFI, where every health director across the state comes together bi-weekly to talk about what's going on. And it should be no surprise that a lot of the issues that I see in North St. Louis and predominantly Black communities mirror what we're seeing in rural environments. I've gained relationship and we collaborate with these folks. So what I'm able to do in providing Narcan to communities, in building the first ever behavioral health bureau, we provide them with the same protocols, and I can share that with my counterparts in the same way that they're able to inform my leadership. I could say so much more about the latter part, but I talked too much today and we're 2 minutes over, so I'll stop there.
No, thank you so much. This was a fantastic talk. There's so much to dig into. I have like 5 or 6 more questions written down on my legal pad in front of me that I may have to ask you at another time. But thank you, Dr. Hlatshwayo Davis, Mati, for joining us.
Knowing how to say my name. That's how you know the relationship is real. Nothing that says you.
I've had a long time to practice.
Thank you so much for having me. Thank you all for joining.